Thank you for that very kind introduction. All right, looks like you guys can see my screen, I think. And yes, I would love to visit India in person one day and try all the dosas, and especially because I need to try all the different types, right? I think it would only be fair for scientific purposes for me to try each of the types homemade on their native soil, and then I can decide which is best. Although I imagine I'm going to offend a lot of people if I judge one better than the other. Thanks for having me, and for all of you sticking around. I know it's late at night there in India. It's the middle of Sunday morning here for us in the East Coast of the United States. I was asked to present on bone pathology, which is not maybe a topic I would have chosen because bone pathology is really hard. Even for me as a bone and soft tissue pathologist, I still struggle with bone pathology cases all the time. And so I am going to try to go in 30 minutes is a short time to cover this topic, but I'm going to try to give some broad strokes, some general tips and tricks, and some pitfalls to avoid so you can stay out of trouble when dealing with bone pathology cases. All right. That's the picture that you were referring to. Thank you so much. It's actually, I think, my most liked and retweeted picture of all time, probably. And my girls, that was, I think, 2016, maybe. Yeah. So about 5 or 6 years ago, we did that, and they look really well behaved. But my wife and my fellow were both right there behind the scenes, and we prompted them with pizza and stuff, getting them to sit still for that one quick snap. And when they're teenagers, we'll recreate that photo maybe if they allow me to. We'll see how they feel. These are some disclosures. The only thing that's really relevant to this talk is that I do make some money from YouTube and Kiko. If you view my posts or videos on those platforms, I do get paid a small percentage of the advertising revenue. I get some of that. So just so you know, I like to make everyone aware of that. But those are free resources. It doesn't cost you anything to view them. And you're always welcome to see all of my financial information related to my conflicts of interest there at that link. All right, and then also speaking, like I told you, of Kiko, I do make some profit off of these, but I have organized all of my videos, digital slides, pictures, etc., into these indices, one focused on derm path and the other on bone and soft tissue. And my goal eventually is to release all of I have thousands of sample pathology report templates. I plan to, as time permits, to edit those and release them online over time so that eventually there will be a complete library, basically like an online fellowship. And then once I've covered every entity, I can retire. And that's my goal, at least. It may take me some years still, so don't worry. So like I said, bone pathology is hard. And I think there's a handful of reasons for this. Number one, soft tissue tumors are rare, right? But bone tumors are much rarer than soft tissue tumors. So rare things are hard to get good at because you have to see them repeatedly. You know, just like anything in pathology, repetition is the key. Well, it's hard to get repetition and get experience when something only occurs very infrequently and you may not see it often at all in your institution, okay? So that's one thing about bone that's hard. And difficult. The other thing, of course, is that in the pathology findings have to be interpreted in the context of radiology. It's always true in pathology that we have to correlate what we see under the microscope with the clinical information. But in some parts of pathology, that is especially true. Inflammatory dermatopathology, for example, you really have to know what it looks like, what the presentation is, to see if what you're seeing microscopically makes sense. Bone pathology, that is so true, and instead of it being the clinical appearance, it's actually the radiographic appearance of the findings that have to make sense with the pathology findings microscopically. All right. The other things that there are some significant differences in treatment depending on the diagnosis. You know, chondrosarcoma versus osteosarcoma, very different treatments sometimes. You know, osteosarcomas are chemotherapy sensitive. Chondrosarcomas really are not. And there are a lot of other differences as well, but sometimes the distinctions are very important. You're often getting a small biopsy or curettage sample. It's harder to get a large sample in bone pathology because it's more difficult to get access to the tissue, right? To do the biopsy is more complicated. And also, likewise, the other surgical problem is that complete removal is not always an easy thing, right? In soft tissue or skin, you can say, well, I'm not sure what this tumor is, but I think you should completely excise it with negative margins just to be on the safe side, right? We do that sometimes. I do, at least when I can't classify something or I'm a little concerned and I'm not really sure how to deal with that. I say, well, let's just remove it, cut it out, right? Well, how do you do that in bone? It's not always easy because cut it out might mean the replacement of like the proximal femur and the femoral head with a new joint, right? Expensive, problematic, complications. The joint may fail eventually. It's not a minor thing to say to do a whole resection on block of part of a bone, right? Or they go and they can scrape and curette out the entire thing, but I mean it's a big difference sometimes surgically. So it's not always as simple to just say, well, just remove it and get negative margins. That's more complicated in bone pathology. And then here's some rules and tricks. Okay, like I said, you must compare the pathology findings with the radiology. Ideally, it's great to be able to see the imaging, the CT scan, the MRI, the X-rays with your own eyes if you're able to. I know a lot of times that's not practical, especially in if you're in a tertiary center. Sometimes the person was referred from outside, and their radiographic imaging studies may be at an outside facility. And even here, I know in the United States we have this problem where it's sometimes challenging to get all of the information from someone's records at an outside institution into the records of our institution. So if you can't see the imaging yourself, at least seeing the report can be helpful. And that's for a couple of reasons. One, you get a chance to see how big is this? What does it look like? Is it destroying the bone? Does it have a benign or an aggressive malignant appearance radiographically in the opinion of the radiologist? The other thing is that you can read the radiology report and see, does this radiologist seem like they know what they're talking about when it comes to bone tumors? And I don't mean that as an insult, but just like bone pathology is difficult for many pathologists, maybe for all pathologists, I don't know, that's probably closer to the truth. Some pathologists are quite good at bone pathology and have a lot of experience. Some pathologists almost never see bone pathology and really struggle with it and don't even know where to start. The same can be said for radiologists. We all think radiologists should be good at all radiologists should be good at this because they all look at bones. But remember, because bone tumors are rare, many radiologists have only limited exposure to bone pathology, right? So I think that's a kind of misconception among us as pathologists that we assume, yes, they all surely get training in it to some extent in their residency, but there are plenty of radiologists that are either subspecialized and never deal with musculoskeletal tumors, or they just rarely encounter them and don't have a lot of experience. So sometimes I'll read a radiology report and the differential the radiologist gives tells me that they really don't know what they're talking about when it comes to bone pathology, or soft tissue tumors, because they'll list a differential that doesn't make any sense at all to me as a sarcoma pathologist. And then what that tells me, I need to get that radiology disc, the actual report, and have my musculoskeletal radiologist review it to see what they really think it looks like, or I need to see it myself. Now that takes extra work, and sometimes it's not possible, but when you can do it, it can make a crucial difference in the diagnosis. And then these other things that are kind of common sense, but how old is the patient? Most importantly, is the skeleton mature? Have the growth plates fused, or are they still immature and have growth plates? That can make a big difference in what type of tumors are likely to arise at that age group. Is the tumor arising in the extremities, the appendicular skeleton, or in the axial skeleton, the spine, the ribs, the pelvis, the skull? Because very different types of diseases present at different sites, and also sometimes the features of those diseases can look different microscopically. Also, when you're in the extremities, are you talking about a long bone like the femur or the tibia, or are you talking about the short bones like the tarsals and metatarsals and carpals and phalanges? Because certain tumors, like cartilage tumors, we'll talk about in a minute, they can look very different when they're in the small bone of the finger versus when they're in the long bone of the thigh, of the femur, or in the humerus or radius. The rules of what's allowed and not allowed changes depending on what bone you're in or what bone type. And then finally, I can't stress enough, just like in all of pathology, you must know normal histology and you must know reactive changes that are mimics of neoplasia. That is true in derm path, it's true in soft tissue, it's true in bone, it's probably true in all of pathology, is that we often gravitate towards learning about tumors because, let's face it, most of us as pathologists, I think, are pretty interested in tumors, and they're in some ways a little easier to wrap our heads around because we have this entity in this box and we can do this test for it and prove it. And reactive changes are often just, you look at them and make a diagnosis based on morphology that, yes, that's benign reactive change, not cancer. And that's really hard sometimes. And it's something I still struggle with, even though I really focus on this and practice it and teach about it. I still struggle with it sometimes in my cases in real life. You cannot spend enough time learning normal histology and reactive. It will help you so much to avoid problems in your practice, all right? You must compare just in case you didn't get it the first 5 minutes, you have to have the radiology. So if it doesn't make sense radiographically, if I think it's a, osteosarcoma, and then the radiologist is like, this is a 1 centimeter thing and it's not, well, then I need to step back and reconsider. Am I sure that I'm right? And if I'm not sure, a lot of times then I'll send that out to another bone pathology expert who's more expert than me to get their input. Because I'll say, if it really doesn't make sense with if the orthopedic oncologist, the sarcoma orthopedic surgeon, and the radiologist don't think that my diagnosis makes sense, then I need to stop and get a third opinion to see. And that's an area where you can't let your ego get in the way of patient care, okay? If I'm wrong, well then great, I get a chance to learn something in the process and the patient is spared from being mistreated potentially, okay? If I'm right and I've sent it out and the expert agrees with me, then I just earn some credibility and respect with my colleagues, right? So I feel like I win either way. So I'm really quick to say, hey, let's send it out and get another expert opinion if there's any discrepancy, because I think that makes everyone's mind at ease. And it also gives me a chance to kind of do quality assurance on my own diagnostic skills and to make sure that everything matches up for patient care. And like I said, talking to the radiologist and the surgeon and putting all the pieces together, it takes time and effort. I understand. And I know that we're busy, but sometimes doing that can make a difference, a dramatic difference in patient care. You might be the last person standing between saving the patient from a misdiagnosis or a mistreatment. So take that opportunity and be an advocate for your patient, okay? So there have been times that in the past, I used to take consults. I've stopped doing that because it was too overwhelming with my schedule. But I have had times where I tried repeatedly and I could not get the radiology. So in that case, I signed out a report and said, well, here's the descriptive thing. Here's some of the differential diagnoses. It has to be compared with radiology to make a definitive answer. And unfortunately, despite repeated attempts, I wasn't able to get it. One time I did that, and the next day we got a call or a fax from that institution. They said, oh, we're really sorry we missed your calls. Here's the radiology you requested. That's right. So I wasn't trying to be a jerk. I was just trying to say what's honest and true for the patient. And in cases where it really is unavailable, and I know that even if it's a struggle here, I know it must be a struggle around the world, that sometimes you just can't get the information that you need. So there you go. So the reason I know that none of this is pictures, right? But this stuff is the crucial stuff. You have to know this before you even start thinking about the pictures and the diagnoses, because these are the ways that you keep yourself from getting in trouble or hurting people, okay? Now let's go further. These are some videos I have on both Kiko and on YouTube. I basically have all the same videos on my Kiko channel and my YouTube channel. Pick whichever one you like. This is a video. I had the great pleasure of having Andrew Rosenberg sit with me for like 3.5 hours one afternoon. He is such an amazing teacher, an incredible bone pathologist. He's at University of Miami, but he spent most of his career at Harvard. And just a great guy, really fun. And he came to give a lecture to our residency a few years ago at a different institution for graduation. And I asked him, I said, hey, will you sit down and show me some slides and we'll make a YouTube video? And he said, yeah, sure, let's do it. And so it was just an amazing masterclass of bone histology, embryology, pathology. And what a privilege for me to get to sit and learn from him. And I probably should go watch these videos multiple times because there's so much stuff in there that I could refresh my memory on or was learning for the first time. So you can go check that out. It's a great, if you need an overview of all the basics, that's the basic histology. And he did another one for cartilage that same day, so you can check those out. Those are the links right there. Feel free to take a screenshot while I take a drink of water. And I can send this PowerPoint to the meeting organizers once I'm done here. All right. So that's lamellar bone, right? Normal lamellar bone, and you can see the haversian canal in the middle where the blood vessels are, the little lacunar spaces where the osteocytes sit, and the concentric lamellar bone lines that kind of come up and merge into one another quite beautifully, right? This is normal, mature bone, all right? This is the normal bone. And you'll see this both in the cortex and in the bone trabeculae, all right? Now, up here you can see this is lamellar bone, right? And over here we have new woven bone, new bone that's being produced by these juicy, plump osteoblasts. Note the background that's loose, edematous, myxoid almost, that looks a lot like nodular fasciitis. That is, to me, so helpful. When I see new bone production, woven bone can look really wild and scary sometimes because the osteoblasts are big, plump, almost plasmacytoid cells. They can have mitoses. And so you see that, and you see these little fine strips of osteoid-like stuff being laid down, this woven bone. It can be very scary in appearance. Seeing a background that looks fasciitis-like or like reactive myofibroblasts that's loose and myxoid or edematous, and then seeing weird looking bone, that is a sign that makes me think this may be reactive bone or reparative new bone formation, okay? Anytime you see woven bone, and I'll show you another picture in a minute, is basically an abnormality. It's pathology. Even though, yes, this is how our body repairs bone, so it's what the body is normally supposed to do when it's, say, fixing a fracture, but it means that there has been either trauma, damage, injury to the bone, or sometimes different diseases, including some tumors, can produce woven bone. So woven bone is always a sign that something's abnormal here. It's not normal anymore. Here's a closer look at those osteoblasts. So when you have times that you know something's a fracture callus, or you know that they're removing an orthopedic hardware and replacing it with a new one, you know that it must be reactive. Study that reactive bone as much as you can so that when you get a biopsy and you're now worried about something being tumor versus reactive, then you'll be more comfortable with the wide range of weird features you can see in reactive bone. And I give that advice to my residents and fellows and everyone. That's true in derm path, in all of pathology. When you have a chance that you know something is benign and reactive, study those exuberant, definitely benign reactive cases so that you can deal with the harder cases where there's uncertainty clinically about whether something's a tumor or a reactive process, because it will help you. It will help you build up your diagnostic skills and your ability to recognize those challenging things. And here's another case. This is an unusual rare disease that you can see down here. This is the cortical bone, and it's got the nice lamellar bone lines. And then up here, this is woven bone. And so woven bone, look, instead of the concentric bone lines, you have little thin strips of collagen. Remember, bone is made of collagen type 1, onto which calcium hydroxyapatite is deposited, right, by the body. So it's not just calcium. It's got to have that collagen underlying network of fibers. And the fibers, when they're arranged concentrically, that's the lamellar bone. And when there are these little lines that are just haphazardly woven together and intermingled like that, like fabric almost, then that's woven bone, okay? And if you're having trouble, you can flip your condenser. If you have a rack-mounted condenser in your microscope, flip that up and down, and flipping your condenser down and off, it makes three-dimensional objects stand out better. It makes woven versus, it makes the bone lines and the collagen stand out. It's really great in soft tissue to show collagen and elastic fibers. Works beautifully for keratinocytes. Anything that's got a little bit of three-dimensionality or kind of cell-to-cell distinct boundaries, sometimes flipping that condenser can really help. Try it out. It's real fun. And it's really good, too, when you're taking photographs microscopically. Sometimes that'll help you take a much better, more crisp photograph. So I often experiment with that. All right, so let's talk about osteosarcoma, right? I mean, one of the classic and important, crucial things we need to know in bone pathology. Obviously, these are malignant tumors that have the ability to produce bone. They are most common in kids, children, and teenagers, but it's important to note they can really occur at almost any age, except really young babies. Like if they're an infant, it's very unlikely to have osteosarcoma in a very young kid, like 1 or 2 years old, extremely rare. I think even before the age of 4, it's very rare to see osteosarcoma. And then it really kind of starts to peak as you get into the 10, 12, 13, 14, 15, that age range. And then there's another peak later on in adulthood around 60 or so, 50s to 60s, I think. And then anywhere in between. I've seen osteosarcoma in pretty much all age range except very, very young babies. So even just that's important to remember that adults can get osteosarcoma. Even though it's much more common for children and adolescents to get it, it can happen in adulthood, okay? So here's an example of an unfortunate patient who had an amputation for a very advanced osteosarcoma. You can see the tumor is growing here, and it's pushing down into the medullary space of the bone and destroying that. It's also expanding out, destroyed the cortex, expanded out and invaded the soft tissue. And on an X-ray, you can see even here this whitish area. All of that is calcium deposition, right? It's osteoid that has calcium deposited on it. And so on X-ray, one of the characteristic features is you'll see this destructive tumor in the bone that's depositing mineral calcium, which looks white on X-ray, in the soft tissue. And I think that's why CTs and MRIs are really helpful, but I really like seeing plain film X-rays. Sometimes regular X-rays can show features that don't show up as well on MRI or CT, surprisingly, because it's a simpler, more primitive maybe technology, but it still works beautifully for a lot of things. So I really like to see the X-rays in addition to those more advanced scans. Here's a different patient, and this is a case from an old-timey collection that was beautifully done of a whole mount bone specimens, and I'm working on getting these scanned. It's really hard to find someone who can scan these large slides, but I'm working on that, and hopefully in the sometime in the next year or so, I'll be able to get this really amazing collection scanned that Dr. Aubrey Huff, a senior bone pathologist at my former institution, kindly donated some slides to me for teaching purposes. So here's 2 hole mounts. This is one slide here and then the other that I've stitched together. But you can see this is the end of a long bone, and the patient still has a growth plate right there. And you can see this is the cortex. And what's happened at the edge where the periosteum would be, it's lifted up and elevated. And you see strands of bone, osteoid, being deposited out there. That's that sunburst pattern that you'd see radiographically. This is the periosteal elevation, the Codman's triangle, all the stuff we learned in med school. That's a perfect example of it in a rare view that nowadays it's really, really hard to find anyone who even knows how to cut sections like this. So I feel incredibly lucky to have a chance to see and to actually get some of these from my collection. And I can't wait to get them all scanned to share them with the world so that all of you can learn, because it's just a great way to see the exact classic way that these tumors are supposed to grow. There's a closer look. Remember, that was what the Codman's triangle would be. So this is really typical that osteosarcoma permeates and destroys the cortex and then grows and expands outward from the cortical surface into the soft tissue, often leaving osteoid deposits behind in its wake and elevating and lifting up that periosteum. And here is an X-ray scan of the same specimen. This was taken outside of the patient. Obviously, this was on the resected specimen, and you can see, look, there's the Codman's triangle. There's the elevation of the periosteum. Here's those sunburst kind of radiating rays of osteoid, the white here equaling bone with mineral, with calcium deposition. You can see this fluffy, flocculent material here on the other side in the soft tissue and replacing the central medullary space of the bone, okay? And this is what we see in osteosarcoma microscopically. Now, I could give a whole talk for like an hour just showing nothing but osteosarcoma pictures because there's many different patterns. There's multiple different subtypes, okay? But the key is we're seeing something that looks like a malignant sarcoma, right? Ugly spindled or sometimes epithelioid cells, depending, and producing little strips, little seams, or lace-like bits of osteoid. And this is what we're talking about. Osteoid is this. Now, sometimes people will say, is that collagen or is it osteoid? And the answer is yes. Yes to both, right? Because osteoid is made of collagen. So sometimes little streams of collagen in the middle of a sarcoma make me think, could this be osteoid? Well, you can try to say, well, if it's a certain amount of waviness, then maybe it's, osteoid. But I like that one of my mentors, Mark Edgar, said that he thought the more objective and honest way is the best way to tell is if you see pink stuff like this and it begins to turn purple and produce mineral, that means it's picking up calcium on top of this and it's being directly deposited, intermingled directly with the malignant tumor cells, then that's definitively osteoid. Now, it does depend to some degree on your decalcification. I think there are times where you can decalcify and make all of that purple kind of go away. And this is one reason that I like to always include at least one block non-decalcified in bone tumors if possible. Some bone tumors are too hard entirely and you just can't do it. But if there's any area that's soft enough to maybe cut through with the knife, even if it's gritty, I like to submit one of those blocks without decalcification. Number one, it's sometimes helpful in osteosarcoma and other tumors to get an area that doesn't have the decalcification artifact because, decal makes the nuclei wash out and it also dissolves away the mineral, and sometimes those can be helpful diagnostic features. Also, there are times, and admittedly, even in my practice where I have access to molecular testing, I don't use molecular on bone tumors very often, but when you need to, if you decalcified it with hard original type decal, like it destroys the nucleic acids and it's impossible usually to do FISH or RT-PCR. One alternative is you can use a weaker, more mild decalcification like EDTA. EDTA usually will decalcify, it takes a little longer maybe, but it usually preserves the nucleic acid, so you can use that if you need to. On bone biopsies, when we do decal, I want to basically always use EDTA. On big, bone tumors, it may be not be practical to use EDTA, but you want to be careful because the stronger decal sometimes can really destroy and degrade not only the DNA and RNA quality, but also the nuclear features that you need to make the diagnosis. So again, that's what we're looking for. And look there, you can see this little lace-like wisps of osteoid being produced by malignant tumor cells. That's osteosarcoma and all the stuff we just talked about there. All right, now let's move into an unknown case. Look at that. There's osteoid. And I know you can see pink here. It does mineralize elsewhere. I didn't show the area with mineralization. Very big, plump cells laying down osteoid, being entrapped in the middle of it, right? Very scary looking. Looks like osteosarcoma. But one clue here to make me stop and think is out here, it's very loose and edematous, almost like kind of nodular fasciitis look. And then look at this, some atrophic skeletal muscle cells in the middle. Now at lower power, we can see actually this tumor is centered in the skeletal muscle. I'll tell you that because I'll show you the imaging in a second. And it's got a zone. There's a zone of this robust woven bone osteoid production, and then it matures a bit towards the middle. So it has this kind of like shell-like layers as you go inward towards the center. And here's what happened. We have this is a really awesome case because we had the ability to see a pretty nice incisional biopsy. And then for kind of complicated reasons, they ended up waiting 6 or 9 months to remove the rest of it. And so early on, it looked super scary, very cellular. And there it is right here. It's not actually in the bone. It's this ring of bone in the soft tissue next to the bone. On the alternative view, you could tell, and on the CT and MRI, it did not connect to bone. And then here you can see it again. It's kind of gotten a little more solid. And look, when they finally excised the whole thing, it was not this immature bone anymore. It was now mature bone with kind of a burnout fibrotic backgrounds. Here's the early view on the initial biopsy, very busy, but look at that loose fasciitis-like stuff. And here's the same exact lesion 6 to 9 months later. It's basically like almost mature lamellar bone. It has totally matured and turned into mature bone. And you've got a little bit of loose fibrotic stuff with edema in the background, and all that busy, scary stuff is gone. So this is the natural course of Myositis ossificans, and this is the only case I think that I've gotten to see where I had the really nice early sample and then late sample of the same exact lesion, and we were able to have that follow-up, and it was great to see that. But when it's early and exuberant, it is very scary looking, and it's a nice template to not just for this diagnosis, but of all the things that produce exuberant woven bone, new bone, reactive bone, whatever name you like, they all can look really scary sometimes. Myositis ossificans, fracture callus, other things. So learning this is really helpful to get a feel for how weird and wild, benign, even though myositis ossificans probably is actually a benign self-limited neoplasm, but it looks identical to other things that are reactive, like fracture callus. So I have a video here. I did a master class. A Path presenter had a master class this summer, and I did the bone and soft tissue session in that. And you can see that on my YouTube channel there. And if you look in the video description, there's a link so you can go and see all the digital slides, including the slides for this case. So I encourage you, go there, go to the video description, check out the digital slides on this and really study them, because this is something totally benign where we had follow-up and it behaved in a benign manner. And go look how scary that thing is. It's scary. Still scary, even now, almost nine plus years into practice, these still can look scary on a small biopsy, especially when you don't have all the features. All right, so the pitfall here is that exuberant, new, reactive woven bone can sometimes mimic osteosarcoma. It can look very scary. You have to have the radiology and the clinical, like always. And some examples are fracture callus, myositis ossificans, and anything that can make metaplastic or woven bone, all right? So let's talk about chondrosarcoma now. So chondrosarcoma is challenging in a different way. There are a handful of features that you need to make the diagnosis. The most helpful ones, I think, are invasion through the cortex and into soft tissue. So destruction of the cortex, invading the soft tissue by cartilage, or infiltrative permeative growth within the bone in the medullary cavity where normal bone trabeculae get trapped and completely encased by cartilage. Okay, so if you can find those things, those are, I think, some of the most helpful features to diagnose chondrosarcoma. And for the higher grade forms, grade 2 and grade 3, you'll have increased cellularity, sometimes spindle cell morphology, extensive myxoid change. I forgot to write that on there. Nuclear atypia. Those things can all be very helpful. And I want to point out one important exception, which we won't go deeply into, but just so you know that in the small bones of the hands and feet, it's okay to see benign enchondromas with nuclear atypia and hypercellularity. You shouldn't see them expanding out and destroying the cortex or having permeative growth, but it's okay to see atypia, sometimes pretty weird looking, bizarre atypia, and still have benign behavior. So that's a crucial difference. Things that in the long bone, like the femur, we would call chondrosarcoma grade 2. If it's a small lesion that's not radiographically destructive and it's in the finger bone, one of the phalanx bones of the finger, then it's probably an enchondroma. So that's an important note to make sure you're aware of, and you can go and read some more on that if you need to. So here's an example from the rib. This is the native rib right here, and this is a massive tumor that destroyed and expanded out of the rib, pushed into the chest wall, had to have thoracic surgery, and there's another bit of rib right here. You can see that ring down there at the bottom. And this is the gelatinous, lobulated appearance of a nice cartilaginous tumor with a lot of myxoid change, hemorrhage in it, some necrosis. Clearly malignant by nature of its very infiltrative, aggressive growth out into the soft tissue. And I can't remember if this is actually the same case or a different case now that I say that. I think it was the same. This is the bone, and you can see the bone trabeculae are completely surrounded and encased by the cartilage tumor. The cartilage is just streaming through. It's like poured in and just filling in all the spaces where the marrow fat used to be. It's all getting filled up with chondrosarcoma. Okay, that is the classic finding you want to see. The problem is this is great when you have a whole resection specimen, but a lot of times when there's uncertainty radiographically, they're not going to give you a whole en bloc resection. They're going to give you a curettage, fragments of lesion, or a needle biopsy, and then the problem, it can be much more challenging. So in those cases, when you don't see good architectural growth to support chondrosarcoma, it can be helpful that when you see this is definitely way more cellular than regular cartilage. Cells are really closely packed together. Maybe a bit of atypia, although it's hard to assess here. Sometimes atypia in chondrocytes I find to be a challenging thing to appreciate because chondrocyte nuclei are kind of small and dark and hard to see clearly sometimes. So in this case, though, this was clearly a chondrosarcoma, and based on I don't see really ugly pleomorphic cells, but I see greatly increased cellularity and extensive myxoid change rather than nice lacunar architecture. So I'd call this a chondrosarcoma grade 2 personally. As with many gradings in pathology, there is some subjectivity, and I think especially so in cartilaginous tumors. So in any case, to me, that's an example of chondrosarcoma grade 2, but other people might decide to grade it a bit differently, and that's fine. All right. Now here is an example. This is, again, you're not even seeing the bone here. This is expanded way out into the soft tissue. Again, it's a cartilaginous tumor with probably a lot of myxoid matrix in the background. And look at it close up. I mean, that's pleomorphism. Bizarre, wild-looking nuclei. I mean, that thing is like 20 times bigger than some of the other neighboring cells. And also, look, a mitosis, another mitosis, 2 mitoses in the same field, right? So oftentimes in cartilage tumors, you got to hunt around for a while to find any mitotic activity. And here, there's abundant mitoses, dramatic pleomorphism, very, very ugly, very cellular. I mean, total myxoid breakdown here of the background matrix. So to me, this is what you would want for a chondrosarcoma grade 3. Basically the same kinds of features you see in chondrosarc grade 2, plus marked pleomorphism, often with mitotic activity. Now I want to point out something important. Grade 3 is rare, okay? Only about 5% or so of chondrosarcomas are grade 3. Most of them fall into the grade 2 and grade 1 categories, okay? So because of the rarity of it, be cautious before making a diagnosis of grade 3 chondrosarcoma. And I'm going to show you why in a minute, because there are some mimics that are really important to not get confused with this. So once I start seeing really ugly, very atypical chondrocytes, then I back up and say, am I sure it's chondrosarcoma? Because it could be one of the mimics. We'll talk about that in a minute. But first, what about grade 1 chondrosarcoma? I showed you grade 2 and grade 3. Well, grade 1 chondrosarcoma is frustrating and complicated, okay? And the reason, there's a few of them. Number one is it looks like this a lot of times. It has very minimal nuclear atypia. There are some like subtle clues, maybe like the WHO book suggests that maybe binucleated chondrocytes, but I have to tell you personally, as a bone and soft tissue pathologist, I find the cytologic features to distinguish a benign enchondroma from a chondrosarcoma grade 1 to be very difficult and difficult to reproduce to my eyes, at least. Maybe there are better people out there than me, but I find them very similar and difficult. So really, I want to go on the growth pattern because these are tumors that don't have much atypia. They're very hypocellular, similar to the cellularity of normal cartilage, okay? So here's an example. There's normal cartilage, and this tumor is actually even less cellular than this normal articular cartilage. So, and this picture right here, I would personally, in my opinion, I'd say, based on that, that could be an enchondroma or a grade 1 chondrosarcoma. I have no way to tell the difference on that one picture. So that makes these very challenging and difficult, especially because what we often get in these tumors is fragmented curettings or needle biopsies where you can't assess the growth pattern. The problem is the growth pattern is the thing that we really crucially need to make the diagnosis. So this puts us into a difficult conundrum, and I really loathe these specimens, honestly. I've found ways to deal with them over time, but I have found them very frustrating over the years because I hate having to hedge and say, well, yeah, it could be either one, I don't know, all right? So again, like I said, low cellularity and minimal atypia or none. And on a small biopsy, if you give me a little piece of it, I cannot tell you if it's enchondroma or grade 1 chondrosarcoma. I can't personally. So to make the diagnosis, really what you want to have is permeative infiltrative growth and trapping the trabecula or destruction of the cortex with soft tissue invasion, like I showed you in that grade 2 chondrosarcoma a minute ago. All right. So here we have, this is the problem, right? You get this needle biopsy, and there may be little bits of bone here and there, but it's really difficult to know. Is that entrapped? Like, I don't know. It might be pushed up against the trabecula. Also, cartilage tumors, both benign and malignant, can make little bits of calcification, is a very common finding. So all of that creates a great deal of difficulty. So how I deal with these in practice when I have a small biopsy or fragmented, I say low-grade cartilage neoplasm. So I can tell them two things. Number one, this is a cartilage tumor, yes. And number two, it's not a grade 2 or grade 3. I can say by the morphology, it is not cellular or atypical enough to be intermediate or high-grade chondrosarcoma. And that is really helpful, actually, because that's the big splitting point, is grade 1 chondrosarcoma is different than grade 2 and 3. Grade 2 and 3 are fully malignant and have the ability to metastasize, okay? Grade 1 essentially does not have the ability to metastasize, although sometimes it can be aggressive locally, it can recur, and a small subset can progress on to higher grade forms of chondrosarcoma, and then they have metastatic capability. All right, so when I encounter this in practice, I say low-grade cartilage neoplasm, and that it could either be enchondroma or a grade 1 chondrosarcoma, and that I can't tell, and they have to refer to the clinical scenario and the radiology findings, and that I don't see any obvious permeative growth, but I really can't tell because it's a curettage specimen. That's how I deal with them in my practice, and I admit that I don't really love that, and I've met other people, experts like Andrew Rosenberg, that don't really prefer to do it that way, but this is the way that I've felt comfortable handling them in my practice. Now, there's an important caveat here, okay? The new WHO, the 5th edition, has renamed grade 1 chondrosarcoma when it occurs in the extremities, okay? It's now called grade 1 chondrosarcoma if it's in the axial skeleton, the pelvis, the spine, the ribs, the skull. But if it's in the long bones, if it's in the extremities, then it's called central atypical cartilaginous tumor. Central there means one's growing in the medullary cavity, growing out of the middle of the bone. There's also a peripheral form, which grows on the surface of the bone off of the top of osteochondroma, okay? But basically, the analogy here is this is analogous to the way that we deal with atypical lipomatous tumor and well-diff liposarc, like Dr. Goldblum just talked to you about earlier, that when it's in the extremities, we call them atypical lipomatous tumor, but in the retroperitoneum, we call them well-diff liposarc. Same tumor, but the behavior and the prognosis is very different, mainly by nature of the surgical accessibility of the sites, right? In the extremities, you can remove these grade 1 chondrosarcoma, or these atypical cartilaginous tumors, and get good results, and maybe it recurs, but then they can go take it out again. Whereas if it's in the pelvis or one of those bones, it can be much more problematic and difficult to deal with surgically, okay? Grade 2 and grade 3 chondrosarcoma, doesn't matter where they occur, they get the same name. But this is an important distinction for grade 1. And when I've made this diagnosis, I basically add a comment that says, and I put quotes around the name so people know I'm not making up this name. This is actually the proper name the WHO gives this. And I say this is the WHO 5th edition terminology for grade 1 chondrosarcoma when it occurs in the appendicular skeleton. All right. So here's another unknown case, and I think I'm getting short on time. So you guys, if you want to stay and listen, I'm happy to keep talking until the end. I got a bit more to go here. If I need to be cut off, then the organizers can jump in and say that's enough from you. But let me at least show you this one case because it's very, very informative. Okay, so here is a biopsy, and this was an extremity of an elderly patient, large lytic lesion, destructive, very aggressive looking on imaging. Okay, so this is the biopsy that came out. Here's another area, and you can see some cartilage focus here, some soft tissue. Look at those chondrocytes. Big, weird, bizarre-looking cartilage cells. Very cellular. I mean, that does not look like normal cartilage cytologically or by cellularity. Pretty weird looking. But then as we look around, we see there's, in addition to cartilage, there's some bone. There's also some like kind of osteoid here, and then this spindle cell component here. Here's a closer look at the cartilage, kind of merging into this woven bone. And then there's some areas with groups of atrophic skeletal muscle with this loose spindly material in between. And looking closer, you can see this has little myxoid cystic degeneration and kind of that feathery tissue culture appearance similar to nodular fasciitis. And that's the same thing right here. This is similar to what you see in myositis, right? When you have proliferative myositis or myositis ossificans, you get areas that have fasciitis-like look in a checkerboard pattern with atrophic skeletal muscle. So that is the clue here that, wait a second, maybe this is not a malignant bone or cartilage tumor. Maybe this is a reactive process. And let's go back to that first picture I showed you. It's easy when you have a bone tumor to focus in on the stuff that looks like it should be coming from bone. But what about this big piece here? Plasma cells, atypical sheets of plasma cells that were kappa light chain restricted. So this case is important because I saw this case long ago, and it had actually been looked at initially, I think, on a frozen section, and the thought was that it was a high-grade chondrosarcoma because of those big atypical chondrocytes, which seemed to fit with the radiology of an aggressive bone lesion. Thankfully, there was no definitive treatment was done at that time, because that would have probably resulted in an amputation of the patient's arm. And here, this is actually a case of myeloma, a large mass of myeloma. I think when they went and worked the patient up, they found that it was a myeloma, not a plasmacytoma. Obviously, you have some other clinical and laboratory features to distinguish those. But in any case, we have a clonal plasma cell neoplasm here. And all of the bone and cartilage, that was reactive. This tumor, the myeloma, had broken through the cortex, and the bone trying to repair itself, basically making fracture callus, was all reactive. But it's easy to get focused on that and to miss this stuff, which I remember seeing the frozen slide. I don't have a picture of it, but it was actually very pale, and really the cartilage stood out much more prominently. So this is a really important case because it's so easy to fall into this. So that seeing that fasciitis-like background to me is really helpful in thinking of maybe this is reactive and not neoplastic. Now, you do have to remember sometimes bone neoplasms break through the cortex, and then you get reactive change in soft tissue also. So it's not a perfect thing, but it gives me pause and makes me think, is there any chance this could be reactive atypical cartilage rather than malignant cartilage? So that's the thing here. The exuberant reactive cartilage can mimic chondrosarcoma. You have to have the radiology and clinical context. And just remember that when you see reactive woven bone or fasciitis-like changes next to atypical cartilage, stop. Stop and think, could this all be reactive? Because reactive cartilage can look really bizarre. All right. Now here's another case. This was from a 12-year-old kid with a destructive bone lesion in a long bone. And you can see it's myxoid, cartilaginous, and chondroid. Very atypical cartilage, cellular cartilage. Areas like this with kind of more rounded cells clustered together. I mean, this looks, like malignant. Looks like a grade 2 chondrosarcoma, maybe even grade 3. And I don't see good pleomorphism here, but definitely atypical. But then look at these areas. We've got lace-like osteoid production by tumor cells, all right? So this was a chondroblastic osteosarcoma. And that's another really important pitfall, that osteosarcomas that are chondroblastic can have really wild-looking cartilage. Much more atypical. The cartilage in a chondroblastic osteosarc, to my eye, is often much more atypical than the chondrocytes that I see in most chondrosarcomas, kind of paradoxically. So the important thing here to remember is in a child, a skeletally immature individual, a malignant appearing cartilage lesion is chondroblastic osteosarcoma almost always, until proven otherwise. It's chondroblastic osteosarc, not chondrosarc, because chondrosarc in kids is vanishingly rare. I'm sure it's been reported, and I wonder if some of those are real or not. But I'll tell you this, I think the youngest person I've ever, and I've seen many chondrosarcomas now, the youngest chondrosarc patient I've ever seen, I think was like 22. And they had, I think they had multiple hereditary exostoses, which predisposes people to getting chondrosarcomas, sometimes at a younger age. So I've seen chondrosarcoma rarely in patients in their 20s, but I've never seen it in a kid or a teenager. I'm sure it may happen, but it's extremely, extremely rare. Whereas chondroblastic osteosarcoma is relatively common as osteosarcomas go. I've seen quite a few of those. So usually the good news is that when you have the radiology, chondrosarcoma and osteosarcoma usually look very different radiographically. To an experienced musculoskeletal radiologist, they can usually sort out the difference. I've seen times where they had trouble and they said it was atypical and it didn't really fit. So in difficult cases, particularly when the radiology is not clear, or in adults who could have either chondrosarcoma or osteosarcoma, you could send it for IDH gene mutation testing if you have that available in your practice. And that can be helpful. If it's positive, it's almost certainly chondrosarcoma. Now, an important distinction here is that cartilage tumors, both enchondromas and chondrosarcomas, can have IDH1 or IDH2 gene mutations, okay? So you cannot use this to distinguish between benign cartilage tumor and malignant. They both can have this. And I think that's something like 60% of chondroid neoplasms, enchondromas and chondrosarcomas, about 60% or so, the last time I read, if I'm recalling correctly, have an IDH mutation. So it's not a perfect test. If it's positive in this context, then it's very helpful and it would support a chondrosarcoma, not an osteosarcoma. If it's negative, it doesn't help you because it could still be a IDH negative chondrosarcoma, or it could be an osteosarcoma, which is basically always IDH negative. So it can be helpful when positive. And it's important here because, like I said earlier, the distinction is important because chondrosarcomas get treated basically with surgery, and radiation and chemo have very little to no impact, unfortunately. Whereas most osteosarcomas are relatively chemosensitive, and there's a certain protocols and oftentimes clinical trials the patients can get into. So making that distinction is actually, this is one of those times it's really critical to distinguish between these, all right? And so here's the differential for marked atypia in chondrocytes. First, think, could it be reactive, okay? And then look for woven bone or fasciitis-like backgrounds, all right? And that includes fracture callus, myositis ossificans, and related entities, including subungual exostosis in the fingers. Also, Nora's lesion, which we used to think, and we don't have time to go into it today, used to be thought to be related to exostosis. Now we think it's probably a distinct entity, although it can have a lot of similarity, but it has some pretty wild, weird-looking cartilage. And you can go and read up on that if you think you have one of those. Most often, those occur on the surface of the small bones of the hands and feet, and rarely it can occur on the surface of long bones. And by the way, I had the privilege to work with Dr. Nora when I was a teenager in a laboratory, and he's such a funny, cool guy. And he told me, I asked him, and I did not know at that time that he had a tumor named after him that he described when he was a resident, by the way, which is just awesome. And I met him, and he was just really outgoing. And I said, Dr. Nora, do you like being a pathologist? Because I was like 17 and thinking about going to med school and being a pathologist. And he said, Jared, I'll tell you this. I come to work every day, and I have fun, and I get paid for it. And I was like, whoa, that's awesome. I want to be a pathologist. And here I am today. And only many years later, after I was actually in practice, did I put together Nora. I wonder if, and sure enough, after I looked it up, that was the Nora of Nora lesion. And now you know that little story, and I hope you enjoyed it. And then also remember, enchondromas in the small bones of the hands and feet can have atypia. Chondroblastic osteosarcoma can have atypia. And finally, think of grade 3 chondrosarcoma, but make sure you've considered all those other things first before you call something a grade 3 chondrosarcoma, please. Because as you can tell, those are all very, very different things clinically, treatment-wise, and prognostic-wise. And I think that's probably a pretty good stopping point. I will point out there's another video that I made in that same session with Dr. Rosenberg, which is about enchondromas versus chondrosarcomas, and he shared some tips and tricks. And I think he holds a little different viewpoint maybe than the WHO in some ways. And that's fine to get different people's viewpoints, but he's a very experienced bone pathologist and just a masterful teacher. I've learned so much from him. And also, I'm so honored, I forgot to mention at the beginning, to present this course right after Jason Hornick and John Goldblum, two people who I've been learning from since I was a fellow and resident, reading their papers and their books, and having met them in person. They're both just such delightful, really wonderful people, and just amazing, wonderful educators. And I've learned so much from them. Every time I hear them speak, I learn a lot. So a great honor to be able to present alongside them to you today. And I think that's probably enough, and you guys should go home and get to bed. And thank you very much for inviting me here to KAPCON. And I'm happy to take any questions now.
Distinguish between dedifferentiated chondrosarcoma from osteosarcoma?
So dedifferentiated chondrosarcoma from osteosarcoma. That's a great question. I think the key there, and that can be really challenging. So one of the things there that really helps is the radiology. So I have a very nice example actually of, if you go to that at the beginning of the talk where I said that the bone and soft tissue pathology page on Kiko, if you go to that page and you search for dedifferentiated chondrosarcoma, I've got a great example in there that's got gross images. I don't think I have radiology, but I have the gross photo and whole slide digital images for you to see, and then a video that goes with it explaining it. But basically, that case was challenging, and one of the first times that I realized that distinction microscopically can be really hard, because that case had very ugly cartilage that looked like chondrosarcoma, and then it had cellular, solid spindle cell sarcoma areas. But in the spindle cell sarcoma areas, guess what? There was osteoid production by tumor cells. So I thought, well, now how do I sort this out? This area that's cellular looks like osteosarcoma. The other area looks like chondrosarcoma. Well, one, it was an adult patient. Two, the majority of the tumor was chondrosarcoma with just some smaller zones that looked like spindle cell sarcoma with osteosarcoma components. And then on the gross and also radiographically, again, I don't think I have the imaging available. It was a long time ago, but on the gross of that case, you can see this is a tumor that fills up the center of the bone and has a very gelatinous chondroid appearance, instead of something expanding out of the bone with all that soft tissue bone production. So all of those things together, and discussing with the radiologist, they said, oh no, definitely this is not osteosarcoma, this is chondrosarcoma. So in that case, it helped me. You could also, that would be a time where applying IDH could be really helpful. If it's mutated, it will help you. If it's not, again, it won't. But that was the way I handled that case. And it can be challenging, but it is actually quite common for dedifferentiated chondrosarcomas to produce a heterologous, or I guess technically it'd be a homologous, but anyway, to produce an osteosarcomatous component in the spindle cell solid areas. And so somehow I had missed that day of fellowship, and I was in practice, and I remember messaging one of my mentors and asking, and they were like, oh yeah, this is really common. And I looked it up in the Cherniak and Dorfman bone book, which is a wonderful book for bone pathology. And of course, it was right there and said this is a relatively common finding. So I think that putting all those pieces together is what helped me. But I've had rare times where I wasn't sure on a biopsy if something was chondroblastic osteosarc or it's a little different than your question, but distinguishing between osteosarc and chondrosarcoma. And on a small biopsy, I've sometimes said, I'm not sure, and I can't figure it out here. And then when they went and got a larger sample, oh, it was actually in that case clearly chondroblastic osteosarc. It was just I had only a needle that showed only the atypical cartilage. So on a small biopsy, if in doubt, express that doubt. And it may not make the treating team happy, but it lets them know, look, we've done everything we can to work this up on the sample we have. We either need a bigger sample, or we need more testing, or we need extra input to sort this out before proceeding, further. So I have had times like that where I just couldn't figure it out, and I feel like I would rather be honest about my uncertainty, and then we can stop and discuss what do we need to do to get to a point of diagnostic certainty. Or if we can't, what should we do treatment-wise to make sure that we've made the best possible decision, in trying to make sure that we're not making a mistake in handling care of the patient. I mean, some cases are really, really challenging, and I continue to struggle. But I find that in those times when I discuss things as a team in our multidisciplinary tumor board, that's often where we make the most progress in figuring out what the next steps are. And that's just been crucial, I think, for patient care. And also in my continued education, the ability for me to tell you all these stories is not just by my experience practicing, but it's by attending hundreds and hundreds and hundreds of sarcoma tumor conferences with my colleagues in all of those other specialties, and seeing the different approaches that they take and seeing what matters for patient care. And that's how I've gotten to the point where I understand what I do today.